Well, hello everyone, and welcome to today's webinar, Clinical Talent, the Catalyst for Profitable Growth. My name's Erica Carbajal, and I'm pleased to serve as the moderator today. And on behalf of Becker's Healthcare, thank you all so very much for joining us. Before we start, I've got just a few quick background housekeeping notes to walk through. So we're going to begin today's webinar with a panel discussion, and we certainly welcome any comments or questions. You should see a Q&A box on the right side of your screen, so you can go ahead and use that to submit any questions that come up as we move through. Today's session is also being recorded, so you will be able to go back and reference it if for any reason you'd like to after the event. And you can access that recording once it's available by using the same login information you used today. And if at any time you're having any technical issues with sound or audio, we ask that you try just refreshing your browser, and you can also use that same Q&A box on the side for any technical questions as well. We're here to help on the back end with those. And with that, we are pleased to welcome our outstanding panel of leaders. To get us started, I'm just going to turn to each of you. If you could share a little bit about your roles and your organizations. Dr. Vallon, can I start with you?
Yeah, good day. I'm J.P. Vallon. I'm the Chief Clinical Officer at Intermountain Health. Intermountain Health is a integrated delivery system in the Mountain West, of the United States, across 6 states, 33 hospitals. We have a health plan with 1 million covered lives, and we have about 400 clinic locations, 5,000 employed physicians and APPs, and 7,000 affiliate physicians and APPs.
Welcome. Dr. Munzer?
Yeah, thank you. And thanks for having me. I'm excited to be on with this great panel. Jared Munzer, I'm the Chief Physician Executive at Phoenix Children's, as well as the Chief Operating Officer of Phoenix Children's Medical Group, which is our employed medical group here in Phoenix. I also lead our behavioral health initiatives, as well as am a co-leader with our clinically integrated network, Phoenix Children's Care Network. And I oversee all clinical delivery and operations for 36 divisions and over 800 providers. Phoenix Children's is in a massive expansion period in time. We've grown a lot over 20 years, and we're again doing that. We have really matured from a single hospital into a hospital system over the last decade, with about 8,000 employees and about 50 delivery sites across the state of Arizona. In addition, as all of you are aware, Arizona is the population growth hub of the world these days, and we have made the strategic decision to open 2 new campuses, one in the East Valley and one in the West Valley, both of which we're excited to announce that we will be opening separate hospitals on those facilities over the next 6 to 9 months.
Thanks for sharing, Dr. Munzer. Prasanna, can I turn to you next?
Sure, happy to, Erica. Yeah, hi, my name is Prasanna Mohanty. I'm the EVP and President of Ambulatory Care for Sentara Health. And in that role, I provide strategic leadership for the direction, expansion, and progress of a $14 billion healthcare network with about 32,000 employees, 12 hospitals, several thousand physicians, both employed and affiliated. And we service 1.2 million individuals in the mid-Atlantic and southeast regions of the US. So in my role, I partner with the CEO and his executive leadership team to develop strategic plans and initiatives that really align with the mission and vision of our integrated delivery network, considering the financial realities of the healthcare industry. So happy to be here with this panel.
Thanks, Prasanna. Dr. Shanmugam?
Well, hello. What a pleasure it is to be with such an august group. Thank you for the invitation. So I am first and foremost a practicing emergency physician and continue to practice pretty regularly. I also serve as the Chief Medical Officer for Emergency Medicine for the Johns Hopkins Medical Systems. I also serve as the chair of one of our hospital's emergency departments, and I'm a professor and vice chair for the School of Medicine. And in those roles, what I find fascinating is that I get to do the frontline work, but I get to spend a lot of time looking at the strategic processes in which we're going to grow and develop. Currently, our Hopkins hospitals tend to be very well oversubscribed, and we are struggling with capacity. Our patient volumes are up, our demand is high, and attracting, retaining all manner of individuals to provide great quality care remains one of our highest priorities as we continue on our pathway to maintaining healthcare excellence.
Absolutely excited to chat more about that. Bess, can I tap you next?
Absolutely. My name is Bess Wildman. I am the Vice Dean for Finance and Administration for the Biological Science Division in the School of Medicine at the University of Chicago. We are an integrated academic medical center, and we're somewhat unique in that we are also very well integrated and contiguous in our academic campus for undergraduates, so that kind of adds an interesting flair. From a healthcare delivery standpoint, we serve the greater Chicago community with an emphasis on the South Side and the Indiana markets. I've spent my career in academic medicine. I've worked for both public and private AMCs. I've served in department roles, hospital roles, faculty practice, and now really in the dean's office. I just came to the University of Chicago about 7 months ago. And in my first 7 months here, we've been really focused on launching a 10-year strategic plan. We have a newer dean, and this is really about sort of how do we fuel our economic plan, thinking about it around all of our tripartite missions. Our plan is really grounded in our service to the community and specifically to the South Side of Chicago. We have a long history of discovery and innovation, and this commitment to the comprehensive delivery of care and healing for our community. Fortunately, our leadership team really sees the growth along the missions as inextricably linked. And so that does layer in a level of complexity into our strategies, but really is, I think, the grounding point for our strategies as we move forward and think about growth in the coming years.
Well, thank you all so much for being here. We're so appreciative that you took the time to participate in this discussion, and excited to learn more about how you're really leveraging the physician workforce as a driver for growth. And today we're also thrilled to be joined by Meredith Lapointe. She's the Chief Business Officer at AMN Healthcare. Meredith, before we get started and jump into the questions and discussion, I'd love to have you just start off, share a few of the national trends you're seeing, really just give us a lay of the land of what you're seeing across the workforce.
Great. Thank you so much, Erica. What a pleasure to be here with all of you today and to represent AMN Healthcare. So quick background, AMN is the largest public clinical talent organization in the US. We provide comprehensive workforce solutions and support ranging from recruiting and of both perm and temporary workforce across physician, leadership, nursing, and allied professionals. And we also have a large range of tools just designed to help make workforce better. Predictive scheduling and areas to really bring things together. So the topic today is one very close to my heart. Really, how do we view people and clinicians and physicians in particular as enablers and drivers of growth and drivers of better access and better meeting missions to provide top care to communities. So thought I'd just tease the conversation with a few statistics. Now, the first one, just straight revenue. Physicians truly are drivers of financial sustainability and success for health systems. The average physician, and this stat is being updated, it's even higher now, but as of a couple of years ago, a single physician on average drove $2.4 million in annual revenue for their organization. So certainly something where you really need to think, do you have enough physicians to meet those growth aspirations, both financially, but also from a community needs and an access perspective. So the next statistic that I always find interesting is just what we see on the shortage side. So it's still estimated by the American Hospital Association, and BLS agrees directionally, that we'll see about an 86,000 physician shortage by 2036. The numbers range a little bit as we continue to project, and it ranges a bit by specialty. But as we see continued aging and population growth, we're projecting physician and surgeon specialties for demand to grow an average of 3 to 4% per year. The largest area is actually nurse practitioners, who we see almost at that 4% mark per year, which is 44% growth over the next 10 years. So how we're going to do that and how we're going to keep people engaged is very interesting. I look forward to hearing all of your perspective on that. And then the final area, which I think we'll dive into a bit today, is we're celebrating now that physician burnout is less than 50%. In the most recent surveys, sadly, it's 49%. So I don't know that we can celebrate quite yet. So as we really think about what is it going to take to keep physicians engaged, motivated, helping drive that growth, but also giving them the reprieve, the support, whether it's time away or enablers, what does that need to look like to really move that not just below 50%, but to a really reasonable and sustainable level? So I'll hand it back to Erica, but just so excited to be diving into these topics with all of you today.
Yeah, Meredith, thanks for sharing that. I think I saw a report just recently on those physician burnout stats, and really just around making progress, but physicians saying this isn't anything to write home about. So I'm excited to dive into this conversation. So we'll start really just with how you're kind of all viewing the physician workforce as a strategy for growth. I think the workforce, what we're hearing is it really remains a top concern for many hospitals and health systems. It's kind of one of those constants. So considering widespread challenges and capacity that some of you mentioned too in your introductions, revenue and patient experience, how is your organization viewing the physician workforce as a strategy for growth? And what are some of the key factors that are really driving this mindset? Dr. Vallon, can I start with you?
Sure, no, happy to start. It is absolutely a top of mind issue for us at Intermountain. And we've actually taken a look at really doing sort of a strategic workforce plan for our current workforce. As I shared in my introduction, we have roughly 5,000 physicians in APPs across our footprint. We also know that our footprint covers 6 of the 10 fastest growing MSAs in the country. And so there's tremendous population growth with Denver, Salt Lake City, and Las Vegas, Nevada. So there's a huge demand into our communities. One of the things that was really insightful when we looked at our physician workforce, and it was sort of caught us a little bit by surprise and was stark, was that about a third of our physicians and APPs will retire or be at retirement age by the end of the decade, by 2030. And so while we simultaneously need to grow to meet this growing population, we also know there's that aging population. By 2030, 21% of the population in the United States will be over the age of 65. And so the demand of that patient population is also going to be significant. We have a retirement bubble that is about to come on board. And so that has really had us focus on a couple of things. One is thinking about what our workforce looks like and how do we make Intermountain, frankly, the best place to receive care as a patient, but also provide care as a clinician. So trying to figure out how we make it a great place, addressing a lot of the issues around burnout, giving folks the tools to be able to support their work. But then also, how do we actually build partnerships with pipelines, both medical schools, residency programs, training programs, APP programs, so nurse practitioner programs and things, really to kind of bring folks in and build tight connections to be able to grow our footprint. And that is beginning to bear fruit as we look at this. Building those connections and kind of laying out this really clear vision for our physicians and APPs. Some of the things we've done that have been really important as well is giving tools for our physicians. We put into place ambient listening, so launching the DAX Copilot for ambient listening for documentation to reduce documentation burden for our physicians and APPs. That's now available to every one of our employed physicians. Looking at, and we've been deploying ChatGPT in the in-basket to reduce that burden. So those types of things to both free up capacity for our physicians and unburden them, but also to use that as a key recruitment tool as we bring physicians in. And so that's been a really key strategy as we think about our broad needs across our footprint.
Yeah, absolutely, Dr. Valen. Thanks for sharing that. Sounds like two big parts there. One, like you mentioned, building the pipeline, but the first is really how do we make a workforce that attracts physicians and makes them want to stay through all these different support areas, like you mentioned, with technology and freeing up capacity, you know, is such a huge focus area for so many organizations. Dr. Chanmugam, I see you want to weigh in here, so let me turn it to you.
I think you're on mute.
I was really excited by Dr. JP Valen's comments and observations. That pipeline is critical, but I'd like to add a couple other things as well, if you don't mind. And what I believe is that medicine is truly a team sport, and it's getting more to be of a team sport. And so the pipeline of development of individuals on, let's say, the leaders of the team, and maybe that's not the correct term, but you know, certainly the physicians, then the nurse practitioners are critical members of those team. But your nursing folks, your allied health personnel, your support folks, the janitorial staff. And so I have to be fully transparent that some of my work, some of my unpublished work, which I'm hoping to be published soon, really is based on cultivating the team. So that, because what I find is that when my physicians and my clinicians overall feel well supported in an atmosphere where everybody's working together, man, there's nothing sweeter, which is why I'm in my 7th decade of life, but I don't want to give up working clinically, because in at least one or two places, we have cultivated a tremendous team where people really enjoy working with each other. And even though the pay may not be the greatest, the conditions may not be the best, the challenges are overwhelming in terms of scarce resources, what we see are people willing to go above and beyond. And I got to tell you, that's the exciting part. So in my mind, what I'd like to see happen is kind of a wholesale change of how we promulgate the healthcare job opportunities, because respiratory therapists, physical therapists, as I said before, I'm going to bring it up to our janitorial staff, our EVS, they're all critical. And these people really do help make a difference in the care delivery model. The other thing that we're looking at is how do you improve the other adjunct aspects of it? So we're looking at music interventions and cultural adaptations to accommodate patients and the local demographics. I'm going to stop here because I might wax on forever, and I think we need to hear from our other more qualified guests.
Bess, go ahead. I see you take yourself off mute.
I did. I agree that this is going on. I guess the only other thing I would add to this is I think we have to recognize that the provider workforce has different expectations and desires. And I think as an industry, we haven't really found that sweet spot yet. And how do we manage those? And I think, Meredith, your stat on burnout is clear evidence that we haven't found the right balance. And so I think we have an obligation to, if I were to quote Wayne Gretzky, to skate to where the puck's going to be. And we really need to think about how do we shape the healthcare landscape and workforce so that we can grow, but also framed in such a way that we are allowing people to contribute in the ways that feel satisfactory to them. So, the good news is, as a woman, I can say, that the healthcare landscape has changed dramatically. We have a lot more women physicians out there. But we need to think about what are their demands and needs, and how do we, we talk about balance, but balance sounds like you have to give and take. I think it's just designing a system. We spent a lot of time thinking about what new models do we need. So, we have a traditional academic faculty, but now we're recognizing that that we need a predominantly clinical faculty, and perhaps we need to think about how do we have individuals who maybe have retired, who want to come back and work a couple days a week, and how do we design the different phenotypes to make it work? As an administrator, there's a cost and a burden to that. But I think if we don't design our systems that way, we're gonna cut off our nose to spite our face.
Yeah, Bess, I think you raised a great point there too, of just parallel what we've heard from a lot of leaders of they're seeing a lot of physicians, newer physicians coming in that they don't want to be 1.0 full-time employees. Prasanna, let me turn to you too. I know you had wanted to weigh in here.
Yeah, and I just wanted to add to what Beth said. I mean, and also what Dr. Shanmugam said, you know, around the team-based care model, right? I know, you know, we know that nurse practitioners, physician assistants, other healthcare professionals play essential roles in a team. And so how might we create models whereby all members collaborate to enhance access, improve outcomes, you know, while providing the right care at the right time, but also solving for the physician workforce challenges. I love what Beth said around that brings satisfaction to them. One of the things that we've realized as we've recruited for physicians and other healthcare professionals is they want that joy in their practice. Maybe they don't want that full-time 1.0. And so we're coming up with creative ways to say, if you're coming from an academic center, you want to come to an integrated healthcare system, more community-based, are there some aspects of research, clinical teaching, other things that you want to do to bring into, instead of, if you're in primary care doing 100% panel-based medicine, you want to do 80% and maybe 20%. Somebody brings in interest and has a certification in obesity management. So we give them that opportunity. They have joy in their day, joy in their practice. And we feel that that's very beneficial, and that's leading to better retention and better engagement with our physicians. So very excited about what we're seeing. The other thing is leveraging RNs to their top of their license. You know, looking at protocol-based RN clinics in obesity, migraine, wound care, STD, STI, many other ways, ischemia, a lot of other things that we can do leveraging RNs that will then free up physician time as well for more complex cases and when it works. So anyways, just wanted to add those thoughts.
Yeah, thanks, Prasanna. I know I chatted with your CEO, Dennis, back in April, and he talked a lot about the redesigning the care delivery model and how that's such a big priority to support really all clinicians. Dr. Munzer, let me turn to you as well. I saw some head nods from you. I want to make sure, give you a chance to weigh in.
No, absolutely. And I agree completely with just amazing points by the panelists. I think for me, the one thing I would add is I think we have to entrust our physician leaders to be in the room for these conversations and really making these decisions around top of license and how we're going to structure. And we all know, right? We all deal with all the different subspecialists that we have, and it is a little bit different business in every single one of those, and really allowing to look at that operation, getting to top of license, to getting to care delivery, attacking patient access. We have to have those voices at the table. And I would even go as far as to say, as I think everyone talked on here, getting everybody at the table. But I do think, in order to help support the physician burnout conversation Meredith talked about, we have to allow them to have a voice and to communicate their needs and wants. And I think that becomes a critical component to our success in the future.
Dr. Munzer, let me just follow up quickly with you on that. Can you share an example of like how you actually in practice can consistently bring those physician voices to the table? Like what does that really look like?
Yeah, it was really interesting, and I'll go quick, but tell a little history story. When I came in as COO in 2016, I was the first physician in the role, and it became very, very clear that our administrative leaders and our clinical leaders were in really disparate corners of the room. And I really focused on bringing that team together and really saying, it's your book of business. You run the division together, and you clearly know that there's different skill sets between those that have a fiscal education or an operational education or a clinical education. And how do you bring those teams together to say, this is your business. Let's look at your business and how do we operate? And we really, over the last 8 years, have evolved to where that is. And I've had my physician leaders learn finance. I've had my physician leaders learn more and more about operations. I think the top of licensing is a great example. My physicians now know leaders when they come to me and they say, I need another doc, I need another doc, I need another doc. And I'm like, well, it's going to take us 2 years to recruit that super subspecialist that you're looking for, but you already have one. Why don't we support that one with an APP? It's those sorts of questions and involving them and maturing them into those conversations. And now I'll be honest, the majority of our divisions here, it's become the norm. And it really has helped us recruit and fill those hard to fill positions, but also keep the sort of the general positions that we need to really get patient access under control here and working.
Dr. Vallon?
Yeah, I really love the conversation, the dialogue, and I think what you're hearing, which is I think something that we're all embracing, is this concept of flexibility. I think many of us trained with a mental model, and 20 years ago, that mental model of what a physician, recruiting and coming into a practice, whether it was a private practice or an employed practice, and what that actually looked like. It is very different today, and the new physicians coming into practice, they want different things, and so we're looking at all of the things that have been talked about. We're building out team-based care in that, but also looking at ways, how do we embrace part-time? How do we embrace job sharing, where they're truly two individuals that are kind of working together in a partnership. How are we incorporating the opportunity to do some in-person with also virtual shifts? So we have a tremendous telemedicine program across our footprint. And so it may be that one day you're simply doing virtual care, whether that's direct to patient or site to site, with some of our specialists supporting other hospitals and things like that. And then thinking about shift-based models. And it's interesting because that's what people seem to want and are excited for. We're also working a lot with medical schools and others to make sure that the next generation of physicians we're actually doing we're training people for what we need in 10 years, because those entering med school today won't see a patient independently for about 10 years. Are we training them for what we need in 10 years? Or are we training them for what we needed 10 years ago? And I think that sometimes that we're not exactly lined up. And so we need to be thinking about encouraging that team-based care. A lot of the work with longitudinal curriculums that are happening in medical schools are really helping to support that. And then that's been a great way for us to be able to engage, as was shared, the opportunity with some of our employed physicians. It can be an opportunity for them to be teachers or kind of fulfill their need for being academic without being a formally academic physician. And so really trying to create that flexibility, I think that's got to be the key to the future, because there's no longer a one size fits all. We could argue whether one size fits all was ever good, but I think we're learning a lot more from that now.
Yeah, Dr. Vallon, I think you took us really nicely right into the next, I think, stage of the discussion here, just around how you are all thinking about different roles and revenue models too. Meredith, I want to tap you to weigh in here first, and kind of help set the stage as well with any stats you may have.
So no stats on the various roles for this point, but I love the conversation, the point on flexibility in different roles. And one thing that really comes to mind for me at this point is, as we do a lot of recruiting. It's our bread and butter, finding talent, enabling talent, really helping people find the right match and where they're going to thrive. There's so much we can do now with artificial intelligence and just technology that helps supplement that. The human interaction, the connection, and the personal alignment with a mission of an organization where someone works is critical. But as you're learning about someone, as you're seeing how they work, what their skills are, we use a lot of technology just to give ideas of, hey, have you considered this type of setting, or if you considered this location, or hey, this person's going to be a great fit. You may not have immediately identified it based on the surface, but these are the qualifiers that are able to say, 90% chance this person's going to not only be a great fit, but also stay for a very long time. So I think also the more we look at how can we use technology and how can we use that to supplement both finding talent, but also opening the aperture for candidates or for clinicians in role is a really important one. And JP, I love what you said about flexibility on how people work. And Bess, you mentioned earlier as well, folks want to work differently. They have different expectations, different needs. I think there's so much to still unlock on what do the foundations and platforms look like to really enable this, whether it's being more shift-based or really matching your supply of clinicians to what your demand really looks like. I think we sometimes underestimate and say, oh, well, that's tricky. Patients have different unique needs, without fully saying, what would that look like if we were to, actually open up those certain shifts and create different models, different arrangements, different team-based coverage to meet that need. So I'm very excited about where this is headed. I view more consistency and standardization as the next hurdle to get there.
Absolutely, Meredith. I think your comments pull me back to what I heard recently from a physician exec too, who just think really spoke to what you all are saying as well, just around grappling with the reality that we're not going to be staffed to the levels we were pre-COVID. And so how do we get creative and open up ourselves to these different models and things that we never considered before because we never thought we would need them. Dr. Chanmugam, I saw you had your hand up too, so I want to turn to you, and if you could share anything around how you're thinking differently around roles and revenue models.
So, and again, full transparency, this is some of our work that we've been doing. And one of the things that I wanted to pick up from what Dr. Ballin said and what Meredith has said is that, so it's great to create the team, but on the team, knowing what people's strengths and interests are, and then allowing them to maximize them has made a big difference in our ability to create effective teams, because not everyone can be a right fielder, right? And in fact, there's a fair number of folks that really do like taking piles of paper from point A and rearranging it and putting it in point B. For some people, that might be a horrible thing, but for other people, they really enjoy it. And figuring out who likes those things and then getting out of their way to make it happen. And so obviously I used a very basic example, but what I'm trying to get at is that physicians and allied personnel, everybody has their preferences. And even in the same specialty, they have their preferences about how they like to work. The perfect example is the nocturnist group, right? There are some people that you can't pay them to do overnights. And there's other people that that's all they want to do. And so making sure that they fit into that seems to be a challenge in healthcare because we haven't paid that much attention to it. And we are about to publish this paper on eudaimonia, which was first coined by Aristotle, which is allowing people to work what they think is their greatest virtue and what it is that they like to do the most. And very often, if you let someone do what they like to do the most and get out of their way, they're going to do it much better than if you force someone else to do it as part of their quote unquote job description. The other thing I'd also like to bring up is that we do have to talk to people about wealth generation. Too often, individuals are focused on the fact that their immediate salary or the cash on hand is the most important thing, which for all of those that have long-term strategic thinking, that's not the way to go. And that applying wealth generation strategies to their reimbursements or to their, I can never say this word, remuneration package is really critical, right? Because if you can tell someone, okay, you're making X amount of dollars for the next 5 years, and it's a big number, that they're going to be pretty happy with it. But they may be better off with making Y dollars and having these strategically oriented wealth generation packages that guarantee them to be in a net worth class in 7 to 10 or 15 to 20. And I think not enough people have the financial teachings, or maybe it's a society, I don't know what it is, but I think that is one way to address that the workforce needs. So the three things that I think are flexibility, understanding individuals' motivations and where they work best and getting them there. And number three is providing enough education about wealth generation strategies so that people feel comfortable with their entire package. And then I'll stop and allow others.
Thanks for sharing that, Dr. Shanmugam. And I think what you said too, just around understanding motivations and where they work best, brings me back to what Meredith said before this too, just around kind of showing people, really understanding their needs and showing people options that they may not have realized were there before, and really just the widening the aperture component there. Dr. Munzer, I know you had your hand up and I wanted to turn to you, and if you could speak to as well, just any of like the flexibility models that came up earlier that Phoenix Children's has maybe explored or really seen kind of success with.
Yeah, absolutely. And I just want to add, I think I want to comment on Meredith's point that I think is really big. And I know that everybody, the leaders on this call all do this, but I think it's important to state. And I think that is, we all need to be data driven about what the needs are in our communities and understand what those needs are across, in my case, 36 divisions, and some of the other people with bigger programs much larger. But you have to understand that first. And I think that is key before, because that will somewhat drive how and which ways you recruit. And I think that's important. But I agree with you. You know, in listening to this conversation, some great points have been made. And I think I call it meeting. I think we have to meet physicians where they are now. And I think that's something that we have not been great at, and we have to adapt to, and we're going to have to continue to adapt to. And so when you get to the flexibility, Erica, you asked me, you know, I have a 7 on, 7 off with my psychiatrists and my psychiatric NPs, because that's a model that seems to work for them and actually makes recruiting way easier for us. Yeah, they got to work long hours and be on call, but they're getting that 7 days off. You know, I've allowed in all of my divisions with my physician leaders, and I think it was already said here, I think Prasanna said it, you know, we have physicians that want to just be subspecialists on the inpatient side. And so I have an endocrinologist who just does inpatient. They don't do ambulatory, but they save all of their ambulatory colleagues who don't want to do inpatient. And we've done that across probably 5 to 7 of our divisions now, as well as I think the nocturnist versus the non-nocturnist. And then the last thing I'll say about meeting them there, I think Arjun said it great, right? They want to know, it's not how much I'm going to make today. Talk to me about what the future looks like. And maybe they don't even want to know that, but we have to share that with them, because that absolutely helps the recruitment when they can understand how they're going to grow financially. But then also what I'm seeing a lot more of lately is they want to know how they can grow professionally, and they want to know what their opportunities are for leadership. And so whether that's training or showing them examples of people that have come through and matured in the organization to get to leadership in 2, 5, 10 years, also has been a very, very positive recruitment technique for us. I'll stop there.
Thank you, Dr. Munzer. And thank you for bringing up the point around data too. Bess and then Prasanna, if I could turn to you, and if you could also touch on what data or measures specifically you're looking to inform your organization's workforce decisions.
So I love what Dr. Munzer just said around meeting physicians where they are, and also understanding the needs of the market. So we're developing a model that has several different inputs, right? So we want to combine the changes in the supply and the mix of that supply based on our team-based model that I just talked about, combined with clinician productivity, combined with growth targets by specialty, by market, then looking at utilization drivers by risk segmentation. And we're using a new model by Johns Hopkins ACG around risk segmentation, and then other factors to really predict the need for clinicians, not just a year or 2 years from now, but almost like further along. Because if we're going to hire that super specialist, it's going to take more than 12, 18 months to figure that out, right? And so, and to source and to recruit and so on. So we really are being thoughtful and very proactive and predicting and projecting what our needs are going to be by specialty, by market for the next 5 years. And that's how I think we can help kind of get ahead of the trends that we're seeing now, which is, you know, we seem to be at a capacity constraint, sort of access constraint right away. And it takes another 12, 18 months before we get out of it. So we really think, you know, building this model, and we're thinking about it right now, actively working on it, will help us get there.
Prasanna. Bess, can I turn to you as well to share a little bit more about how you're thinking about just what data is really informing decisions at UChicago Medicine?
Leave it to the finance person, right? Obviously, we are looking at a cascade of sort of data elements and benchmarks, but I also think one of the things that we're really doing is trying to do a lot of listening, which there's great data that comes from listening. I think the numbers tell us something about, I think for us, access to care, understanding the metrics around that, understanding the ambulatory environment where we deliver care as a major teaching hospital. I think we do better at some things than others. And we've really kind of had to look to experts out there to help us really better understand how do we make sure the ambulatory environment is world-class and meets the patient's needs there. But then, as I said, doing a lot of listening. So we are doing a lot of growth. We are going into new markets. We are trying different things. We are aligning with what I consider non-traditional partners out there in the industry. And there's a lot of trial and error going on around that. And I think we're spending a lot of time thinking about the data around that trial and error to really respond to both our patients and to our providers, to design things that work very well in our communities. I did want to touch on one thing, as we've talked a lot about sort of the individualized and what faculty or physicians want, and putting things in those different markets, that I think is really important not to lose. You know, a lot of burnout data is around control. And so the hard part with all the segmentation that we've seen go on in healthcare is it's very difficult for one person to sit in control of their patients. And I think at least we still have a lot to learn around how do we wrap around our systems, our data, our analytics, our workflows, to make sure that that information travels perfectly with the patient through the system, so that our providers don't feel like they have the whole story to respond to it. And I just offer that as a place where I think we at least are spending a lot of time trying to do better. And if any of you all got it figured out, I welcome that insight from you. But that is something that I think we as an industry really need to be thinking towards.
Yeah, thanks, Beth. I think great points just around information sharing and getting physicians and providers the data they need. Looking ahead here, what steps can healthcare leaders be taking now to really ensure that their physician workforce supports broader strategic and goals into the future? And within this, what resources, industry-wide shifts do you think will really be essential to meet this aim? Prasanna, can I have you start here?
Yeah, sure, Erica. So I mean, we talked a little bit about workforce projections, right? Utilizing data from various sources to anticipate what the needs are, and we already see things shifting with the aging of the population, and physicians also looking to retire, or given retention rates starting to burn out and leave. So we're already seeing those projections shift. So really understanding what that could look like over the next 5 to 10 years. I think that's really helpful. Training and development, right? Shifting the focus of physician training from kind of memorization to skills, adding skills like that are empathy specific, cultural competency specific, and team kind of based specific, so we can really focus on collaboration and providing that positive, vivid experience through empathy and cultural competence. I mean, those are the things I think will support a broader kind of strategic and growth initiative. Technology integration is a huge one. We talked a little bit about that. Telemedicine is here and growing. Certainly can help expand access to care and reduce physician burnout simultaneously. We talked about well-being programs a little bit around establishing different well-being. It used to be called resilience programs, but sort of well-being programs to address burnout and improve job satisfaction amongst physicians, meeting them where they are, and having them kind of define what they'd like to do with it within the construct of their job and their position, and not only as a job, but as a career within that institution, and creating growth opportunities for them through development pathways and other leadership programs. So I think there's a lot we can do here to really support this.
Thanks, Prasanna. I think one level granular within this question, but I think something interesting to ask about it. We've seen so many pilot programs throughout the last year and a half, whether it be AI, other types of technology. And so I think within this, as we kind of think to the future and scaling things that work, if any of you have any examples of how you are able to really get things in motion when you are seeing a pilot work, how do you overcome any challenges that may make that be a slower process? Dr. Munzer, can I start with you?
Yeah, I think a great example here in Phoenix is we made the commitment to do universal suicide screening and recognize the workforce it would take to universal suicide screen 330,000 children that we put through our ambulatory footprint every year was a near impossibility because they're just not out there. And so we went to technology and we started with a pilot putting so that families and children fill out the forms on arrival. And if they screen positive, we're using telehealth with licensed clinical social workers who are centralized to see every single one of those kids. And it was really interesting, Erica, that what got me to think of this example was the scaling of this. And we're about 80% of the way now. But we started really small, and it's kind of back to the conversation about control and the fact that we had to really work with our physician leaders across all of our divisions, saying this isn't us taking control, this is help supporting your clinic so that somebody who is an expert is handling a problem that you don't have the skill set to handle. And so it really was about how do we align the technology with the operations with the communication. And by putting those three pieces together, we've been able to have success in that program. And I think that is, to tie it back to what I was going to say, I think the one thing we haven't talked about on here, or we've a little bit highlighted, is the retention factor, right? There's the adding of physicians, but if you can avoid losing them, it's just as good, if not better, right? Because you're keeping people that are already in the system. And I think we have to learn how to effectively communicate to our providers. I'm going to say providers because I believe it's the same with our nurse practitioners, our physician assistants, and allied health. How do we effectively communicate to them, and how do we give them a voice? And I think if you can and I think those two things drive a lot of retention. They're not the only things, but I think they drive a lot of retention. And I think we've done a nice job here. We have a shared governance model with a lot of leadership involvement that is really built to be a communication vector for all of our providers. But I do think that's really important to retention, future of the workforce.
Thanks, Dr. Munzer. Meredith and Dr. Shanmugam, I see you both have your hands up. So Meredith, let me turn to you first, and then Arjun, if you can weigh in.
Great. Just building on the recent point on retention, it is such a critical area. And I think one area to really look at understanding retention is to recognize people are in different places, different parts of their careers, different specialty, different aspirations. And how do you design programs where everyone feels like they're getting their needs met, but it's in a way that caters more to them? This goes back to the earlier point, actually, even about wealth creation. What does it look like for an early graduate to have support on student debt, payments and getting rid of all student debt, versus later in life when priorities might be around more flexible schedules or putting down payments on a home or taking time off for family? How do you think through each of those and design programs that really do meet people at those needs without breaking the bank and while still supporting growth strategies? How do you backfill from your volume and productivity perspective while you're enabling your workforce to have that flexibility? It's a complicated puzzle, but I'm confident with the technology, the initiatives that are out there that people are making some very cool progress there.
Yeah, it almost sounds like kind of about like personalization and how do you do that kind of at scale within the organization. Dr. Chanmugan, let me turn to you here too, if you can weigh in on how you're thinking about kind of what might be needed to support the workforce into the future.
Thank you for that. And, this is a nod to Dr. Vallon because I believe his organization has done this very well. And what are the things that really bother most clinicians, patients, and staff? Are the pinch points in medicine. And where are they? On the entry point, on the exit point, and in the transitions of care. I believe Dr. Munson brought this up, that the transitions of care can be extraordinarily painful and involve a huge amount of unnecessary delays. And those delays actually complicate clinicians and service providers' lives. As much as I would like to say that in all my decades of trying to work on an integrated healthcare delivery system, I don't, it hasn't happened. And I find that even transitions among the domains for which I have control, it is still difficult to get a patient from point A to point B, not just in terms of physical movement, but also in terms of care transitions. And for whatever reasons, the science of that has not been elucidated to the point where we can study it and say, hey, this is how we can ameliorate it across all models. And I'll leave it at that because that was my fourth most important consideration that I wanted to bring up in this topic.
Thanks, Dr. Chanmugan. Dr. Vallon, I want to give you a chance to weigh in here as well. If you have any other thoughts on really how healthcare leaders can be preparing now to ensure that their workforces are supported into the future and are supporting the organizational goals as well.
Yeah, I think it's, I think many topics have been well stated here, and I won't repeat them. The workforce plan is incredibly important. We talked about the value at the front end, the value that a physician provides to an organization. The converse of that is the loss when you actually have turnover. And so, thinking Dr. Munzer's comments about retention are incredibly important. And so thinking about how you're connecting with your physicians, with your APPs, with your entire workforce, and engaging them in different ways, I think is incredibly important. Listening, partnering, getting them to be a part of the solution is critically important. That will people embrace what they create. And if we can encourage our physicians and our APPs in particular to help to co-create their workplace and co-create the workplace of the future that is meeting everybody's needs across the board, we will be really successful. So I would just encourage folks to really lean in. The answers probably sit in your organizations with your teams. You've got tremendous talent in all of your organizations with your physicians, with your APPs, with others. Engage them, and I think you'll be surprised at the results that come from that and move things forward. So I'm excited for the future, although it seems daunting. I'm really excited that for the future of healthcare in this country.
Thanks, Dr. Vallon. Meredith, before we wrap up, I know we're about at the top of the hour here. Is there anything else any other points you want to kind of underscore or anything else to share that you feel is important that we didn't really get to cover?
No, I feel like the group covered a number of really critical topics. I think just bringing it all together in sort of what that broader plan, not just from the upfront planning, but also, once you sort of plan what you need and you plan what you have, the ongoing sort of look at that and saying, all right, well, how do we need to make tweaks along the way is going to be extremely important. And the more, the modeling or the data can actually help you do that, the better, because it's overly burdensome for us. But fortunately, we have a lot of help with technology and artificial intelligence and just other tech functions. We just need to figure out a way to make them work for us here. So I'm really excited about it. I think continuing to empower the physician is such a critical part of what all of us do in healthcare. So again, just pleasure to be part of this panel and to get to hear from all of you.
Yeah, thank you all so much. Some really great insights on really a crucial topic. That is all the time that we have for today. I want to thank you all so much again for an excellent discussion, and to AMN Healthcare for sponsoring today's webinar. And for attendees to learn more about any of the content presented today, please do check out the resources section that you should see on your webinar console. And we also kindly ask that you fill out the post-webinar survey. Thank you again for joining us, and we hope to see you again soon.